So, three topics condensed into one lecture. But I would like to tell you guys I'm going to emphasize on the important things you need to know because there's a lot, especially when you talk about certain diseases and then the description of the disease. Okay, mga blah 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 na samok. But anyway, just to make your lives easier, I will be giving you some pointers as we go along. Okay? Okay, so for the diseases of the breast, so you just review the anatomy and physiology, especially the lymph nodes in relationship to the pectoralis muscle, and also some of the important neurovascular structures located in the axilla. The most notable one is going to be the axillary vein. So, of course, you know the blood supply, lymphatic drainage, okay? So these are important things to know. And then, of course, how you examine the breasts. Like, we can use quadrants, or we can use the clock method. And then every lesion that you are going to see is going to have a certain reference point, which is the nipple areolar complex. That is considered to be the central point of the breast. So let's say the lesion is somewhere over here. So this is the left breast. So it's in the upper inner quadrant of the left breast. So don't say left upper inner quadrant. That's kind of confusing. Or it could also be at the, use the clock hands, maybe it could be at the 10 or 11 o'clock position. And then maybe the distance between the nipple areolar complex and the lesion, 3 centimeters, 10 centimeters, etc., etc. So neuroendocrinology, the important thing here is going to be the hormones. There's a good emphasis on estrogen at this point because we know that estrogen can influence differentiation or maturation or increase in the cells of the breast. And then there will be differences of the breast tissue, breasts from pre-puberty, puberty, and then after puberty until the woman ages to menopause. So age-related changes now from Tanner 1 to, you know na. So it's not the Tanner stages. Okay, we talked about physical examination earlier, so there are lesions that you can find in the breasts. Tumors, so lumps, it could be movable, fixed, of course, based on your PDR, you've already gone through this. Skin dimpling, skin changes, maybe ulcerations also. It could be wounds. There could be the presence of a nipple discharge. So for the diagnostics, number one, of course, is going to be history and physical examination. So you're going to inspect, palpate, you do not percuss, you do not auscultate. And then when you come to a point wherein you need imaging, then that is when you can proceed with the two most common ones, which are going to be the mammogram and the breast ultrasound. So they are going to be called screening if the procedure is done just on a routine basis. Like, let's say, for example, a 25-year-old female with a strong family history of breast cancer. So the recommendation is that she has to start having imaging for the breast at 25 years old. So there's just no problem, only the fact that the patient needs to have an examination to rule in or rule out the presence of any lesions in the breasts. Now, these can be called diagnostic if there's already something that has been detected by the clinician, and then you need to check. And of course, in very rare cases, a breast MRI is done. So a breast MRI could be done with in patients with breast implants, or those who have undergone reconstructive breast surgery like a skin-sparing mastectomy, and then you put in a tram flap, latissimus dorsi flap. So those are some examples of flaps for reconstruction. Now, what is important for imaging is the BI-RADS scoring. So what you will have to know what the number means, the recommendation, and the likelihood of malignancy. So 0 doesn't mean negative. Huh? 0 means that the exam is inadequate or inefficient for that individual. So let's say, for example, 49-year-old female gets a mammogram, and then the result comes out with a BI-RADS of 0. So you're not going to tell the patient, "Oh, Mrs. Okay, Rani, you can go home," and then, no, you'll have to do a different examination. It's either an additional view, or you can have the patient undergo a breast ultrasound instead. The real negative is going to be a BI-RADS of 1, wherein the test has been adequate enough to show that there is nothing wrong in the breasts of the patient. So just note that as the numbers go up, the likelihood of malignancy goes up. So the question actually here is going to lie on when are you going to do a biopsy? In most cases, it's going to be at 4. But there are some instances wherein patients would request that you have the lesion removed, even if it's a BI-RADS of 2 or 3. Okay? So imaging is going to be paired up with biopsy techniques. Fine needle aspiration and core needle biopsy are the two, not really most common, but the two readily performed procedures here. Fine needle aspiration is not the biopsy modality of choice because it only aspirates cells. You cannot differentiate an invasive from an in situ carcinoma without seeing cells in their architectural pattern wherein the malignant cells would invade basement membranes. So this is important. Huh? Now, why fine needle aspiration is inferior? However, fine needle aspiration still has its role. So let me give you 2 examples. One, a patient that comes into you into your clinic with no breast mass but with enlarged axillary lymph nodes. And then mammogram or ultrasound just is inconclusive. So fine needle aspiration is the biopsy technique of choice. The second scenario would be for recurrences. So there are patients who would already undergo surgery for their breast cancer, could be breast conserving or not, and then maybe 1 year later, you see a growth on the post-operative site. So you only need to check if there is the presence of malignant cells or not. Because if you see that there are malignant cells, then that's already evidence of recurrence. Or even if there's no lesion here on the chest wall, but an axillary lesion. So then you can do a fine needle aspiration. Core needle is superior because it gets a small tissue sample. So a good representative of the tumor would be a tissue sample with an intact architectural pattern. So you will be able to see if cells, malignant cells, have invaded basement membranes. There's also going to be incision and excision biopsy. Now, these are done on palpable tumors in most cases. Incision is just removing a piece of the tumor. Excision biopsy is removing the entire tumor. Sometimes, when you do an excision biopsy, you can remove the tumor with a margin. Sometimes that is done because maybe you have a high index of suspicion that it's breast malignancy, but then you're not able to, put your foot on it yet. So you just do a wide excision instead. Because in some cases for breast cancer, a wide excision would be adequate. However, if you do a breast conserving surgical technique on breast CA, the patients will have to undergo adjuvant radiation. Incision biopsy could be like, let's say you see a large fulgating mass, or the mass is so large and you don't have the equipment for core biopsy. So, incision na lang. Now there's this instrument called a mammotome. So, it can suction or section tumors up to 3 centimeters, and then it will suction the fragments of the tumor, and then you can biopsy them. Now, there is also a diagnostic challenge for tumors that are non-palpable, or maybe the patient comes to you and then the mammogram result would just say suspicious calcifications by RADS4. So, you can't palpate the tumor. It will be hard to locate the tumor, but this is the time when you are going to employ the use of image-guided techniques. So, one common image-guided technique is going to be needle localization, which is done under ultrasound or mammogram guidance. So, a fine needle wire is skewered through the tumor. So then that is where the surgeon is going to cut and then remove that area. When tumors are removed, especially the malignant ones, ER, PR, and HER2 new receptors are also examined. So, if a patient has ER, PR positive tumors, that means that she can benefit from tamoxifen or aromatase inhibitors. And if a patient has HER2 new positive tumors, the patient can benefit from targeted therapy. The most common one used nowadays is trastuzumab. So for the diseases of the breast, so there's gynecomastia for the males. Now, maybe all of you guys have experienced now when you were 12 or 13 that you felt your nipples getting very hard and a lot. But then it went away after a few months, no? For some people, it's going to be unfortunate because the gynecomastia would actually cause the breasts to grow. So, this is treated by surgery. So, you just remove the enlarged breast tissue and then that's it. So, there are also infections or inflammatory diseases of the breast. So, they could be bacterial or mycotic infections. So, mastitis, infectious mastitis. And in certain cases, an abscess can also develop underneath. So abscesses are to be drained. Infections are to be treated with antibiotics. So there's also Mondor's disease. You see cord-like structures following the path of lymph channels, or hidradenitis suppurativa, parang mga hugawan. No? It's like mga pimple-like lesions that just grow everywhere. So we go to the benign breast disorders. Now, there are classifications of breast disorders, and then this is important because we would suspect certain disorders to be more common in certain age groups. Also, it would depend on the history of the patient. Like, let's say, for example, if the patient had a 5 centimeter breast mass, and then let's say she's 23 years old, and then the breast mass has been there for 5 years, and then it's 5 centimeters irregular border. Compare it to a 60-year-old with similar features. So, most breast tumors usually have a certain response to estrogen. And as women get older, their estrogen drops. So if a woman is postmenopausal and she develops a tumor, the likelihood of malignancy is going to be higher compared to the 23-year-old. Okay? So it's important to know certain conditions that are more prevalent in certain age groups, so that if they come to you, you would know what to suspect and you would know what to do. Maybe you're going to do a biopsy, or maybe not. Maybe you're going to excise, maybe not. So, benign breast disorders are classified into 3. So, the non-proliferative disorders, proliferative disorders, and atypical proliferative lesions. So, for all tumors, the #1 treatment is almost always excision, removal of the entire tumor. But if you have a breast cyst, most cysts actually are benign, no? But when you aspirate a breast cyst, and then it turns out that the aspirate is bloody, then the likelihood of malignancy is going to increase. So this is actually where most of the questions will come from, breast cancer. So breast cancer is the most studied malignancy in the world. Actually, breast cancer is more of a numbers game at this point, no? Now, all you ladies have a 12% lifetime risk of getting breast cancer. It is associated with prolonged estrogen exposure. So if you have had your menses at a later age, you're nulliparous, or you've been taking oral contraceptives, for example, then your chances of getting breast cancer would increase. And there are certain patients with BRCA1, BRCA2 gene mutations who are also at a higher risk of getting breast cancer. But it's not really 100%. The most famous example is Angelina Jolie. She had a double mastectomy, but it was skin sparing, so there's still the skin implant na lang. So, may kapoy kayo ni memorization, no? Now, let me give you the long short of this. If there's any skin involvement, it's going to be repeat, the very least. If there's already supraclavicular lymph node involvement, that's 3C. Now, if you just check the T, most of the time, you're going to get the stage. No? Just look back. No. Ano ng mga clue, or things to make your life easier. So, for the T, the important numbers to remember are 2 to 5. So 1 is going to be less than 5, T2 up to 5, T3 more than 5, T4, of course, it's going to have skin involvement. So there's ulceration, edema, or a fungating mass. So that's going to be T4, regardless of what size it is. Yeah? So we have two forms of staging, right? One is clinical, one is pathologic. So clinical would just be your capnogram, your eyes, the imaging that has been used without the biopsy. Pathologic is going to be with the final biopsy. So there is a difference only on the lymph node side. So if it's the pathologic stage, the number of lymph nodes positive for breast cancer are being counted. So just remember 4 to 9. 1, 2, 3. Yeah. And basta M1 with distant metastasis. Okay? So breast cancer has 5 molecular subtypes. Luminal A, normal like, luminal B, HER2, and triple negative or basaloid type. Now, as we go down, prognosis becomes poorer. Okay? So what's important here are the receptors so that you would know. Triple negative, negative tulog. Ano yung pinakasayon, no? Luminal A, luminal B, let's look at the differences. HER2 or HER2 lang. Okay? So, surgical options would be breast-conserving surgery or radical surgery. Breast-conserving surgery cannot be done on all patients. It can only be done on patients, but there has to be a certain criteria met before a patient can undergo breast-conserving surgery. Then there are radical procedures wherein you have to remove the breast, entire breast, and or adjacent structures also. Like maybe, for example, if the tumor has invaded the pectoralis muscle, you will also have to remove it. So radical mastectomy, modified radical, with lymph node dissection. So if a patient would have to undergo radiation and she's pregnant, she will not be a good candidate for BCS or breast conserving surgery. If a patient has diffuse malignant microcalcification, like let's say the ultrasound or the mammogram showed a lot of calcifications all over the place, so that's not going to be a good, that would be associated with a high risk of recurrence if you proceed with conservative surgery. Poor cosmetic outcome. So the patient, let's say, has small breasts and then the tumor is almost as big as the breast. So, not a good candidate. Diffusely positive pathologic margins. Now let's say the tumor has been resected, a wide resection has been done, margins were positive. A re-resection was done, margins were positive. So, that's not associated with good outcome because you leave a positive margin behind, so BCS is not going to benefit the patient. Okay, so know these. So if these are fulfilled, then if the patient does not have all of these, then she may undergo breast-conserving surgery. Now, one of the things also paired with breast-conserving surgery is going to be sentinel lymph node biopsy. So if you remember in the chapter of skin, especially on the topic of melanomas, a dye is injected in the lesion on the foot, right? And then you have to locate the lymph node, the sentinel node in the inguinal area. For the breast, it is injected on the tumor and the nipple areolar complex. So the sentinel node is then located. The sentinel lymph node biopsy is not going to be necessary or is not going to be of benefit to all patients. It is contraindicated in patients who already have clinically apparent enlarged axillary lymph nodes. So they're enlarged, so just remove them na lang, no? Or if a tumor is greater than 5 centimeters. Now why? Greater than 5 centimeters, pwede pa man. Hindi na, because that patient is already a candidate for radiation. So you just do away with it, it's not going to benefit the patient. So you might as well remove the axillary lymph nodes because you need to decrease the tumor burden and be sure about the status of the axilla for a tumor that is more than 5 centimeters. Okay? Chemotherapy, so the first line regimen is going to be a dose-dense AC, adriamycin and cyclophosphamide, plus biweekly paclitaxel. There are many regimens, but this is the first line in most cases. So, not all patients would need chemotherapy, but if you have this, then the patient would need to undergo chemotherapy. Okay? Now, some patients would require neoadjuvant chemotherapy in order to downsize or downstage the tumor that is present. So, in most cases, patients with stage 3B or 3C breast cancer can benefit from neoadjuvant chemotherapy. Now, why is this so? In most cases, if you have a patient with skin involvement or the presence of supraclavicular lymph nodes, there is a high probability that the tumor has already invaded underlying structures like the pectoralis muscle, or in some cases even the ribs. So doing a radical surgery is just going to be to the patient's, it will just contribute more to the patient's morbidity, because you might end up not being able to close the wound, or you might need to resect the ribs, and then you have an open thorax. No? So those are not really good options at that point. So if you are going to subject the patients to a neoadjuvant regimen, then the tumor might be downsized. It might shrink. So maybe initially it involved the pectoralis, and then after 6 cycles of neoadjuvant chemotherapy, it's just confined to the breast. So it is going to be easier to resect the breast after compared to before, when it had a very deep involvement. So chemoprevention. Chemotherapy is for systemic chemoprevention, or to prevent recurrences, systemic recurrences. Radiation is for loco-regional recurrences. Chemoprevention with the use of tamoxifen and aromatase inhibitors are going to be used for at least 5 years. So patient has to take these drugs every day for at least 5 years. Now, aromatase inhibitors are going to be of more benefit to those patients who are postmenopausal. However, postmenopausal patients can also use tamoxifen. The problem with tamoxifen is the patients might need regular gynecologic checkups. So, kasi nag-check ka ng endometrium, and then breast cancer, mag-endometrial cancer. So, there has to be regular screening or checkups also with an OBGYN. For aromatase inhibitors, one of the main problems with taking them is going to be bone demineralization. So these patients their osteoporosis rather might get worse, and then think that these patients are postmenopausal. So you can give supplemental calcium with vitamin D. Indications for radiation. No? So not all patients are going to benefit from radiation, but if these are present, then that is going to be, these patients will benefit. Another thing to add here is going to be breast conserving surgery. All patients with breast conserving surgery need to undergo radiation because there is a higher chance of local recurrence for breast conserving surgery without radiation. So we mentioned this earlier, no? So just take note of the contraindications. If the sentinel lymph node biopsy is negative, you don't need to perform an axillary dissection. So axillary dissection is for any stage of breast cancer, and in most cases, we only dissect up to level 2. On rare instances, we dissect up to level 3 if we see gross disease. So if there are axillary lymph nodes at level 3 that are enlarged, then that is when we include that in the axillary dissection. If not, then up to level 2 will suffice. So there are several breast reconstruction techniques. So the most common ones would be these three, no? Superior inferior epigastric artery flap, silicone implants, latissimus dorsi, and also the tram flap. Okay, so that's it for breast. So let's go to the appendix. Okay, so there are only two things about the appendix, right? Appendicitis and tumors. So it is part of the normal mucosal associated lymphoid tissue or mouth back. There's the abundance of Peyer's patches in the appendix. So the locations of the appendix are a significant factor in, how do we say this? They're significant in telling the surgeon on how difficult your life is going to be when you operate on the patient. But more often than not, you are only going to find out intra-op. It's rare to find out the location of the appendix pre-op. So the most common location is going to be retrocecal at 54%. There are some na pre-ilial or pelvic. Pre-ilial actually favorite, so we call that a good morning appendix. Paghiwa na appendix ganyan. So sometimes we get that, but most of the time it's a retrocecal. Kamot na lang, yun na lang. So for acute appendicitis, you have to understand how it happens, no? So initially there's intraluminal obstruction. So the term here is going to be what we call a closed loop obstruction. Now what is the loop? That's going to be the question. The loop is just going to be a representation of the arterial side, venous side. This is applicable to end organs, like the appendix or the gallbladder, for example. Now, there is initial intraluminal obstruction. So what happens initially is the venous side gets impeded because there's the accumulation of fluid, or there's going to be edema formation in the appendix. So that's going to contribute to increase in the intraluminal pressure. So, the pressure inside arteries is higher compared to that of veins. So if you press both structures, what is going to be impeded first? The veins, no? So the venous drainage is going to be blocked before the arterial. And later, continuous accumulation of edema is going to lead to accumulation of fluid inside and bacterial overgrowth. So then you are going to see suppurations. With that continuing, this time the pressure gets so high that the arterial side, the arterial blood supply gets impeded. Then you will have gangrene. And later gangrene would result to a rupture. Okay, so that's how appendicitis happens. Now, the classic symptoms or signs of appendicitis would be non-specific or vague abdominal pain that would later localize at the right iliac or right lower quadrant. Sometimes it could be periumbilical or epigastric, then localizing. However, there are some instances wherein the appendix, the pain is going to be in different locations like hypogastric, or maybe right lumbar, so it's a bit higher, or just periumbilical. I think a couple of weeks ago I had a patient, hypogastric pain. Also, pain at the left iliac area, which is unusual. But the patient came to me with an ultrasound result that stated that he had appendicitis. No pain, no tenderness on the right side, only hypogastric, left iliac. And then when we went in, true enough, appendicitis. What happened was the appendix was very long. So the tip was extended to the hypogastric area and a little bit of the right iliac area. That's why the pain was like that. Now, if the patient develops generalized abdominal pain, that is going to be what we call a complicated appendicitis because there's already maybe rupture and then there's spillage of abscess and fecal material within the peritoneal cavity. Sometimes a ruptured appendicitis could have localized peritonitis. Maybe a phlegmon can catch, or the omentum can catch the fluid that comes out, the purulent material that comes out and form a phlegmon. I had another patient, I operated on her last week. She was 76 years old. Came in again with an ultrasound result, ruptured appendicitis, but the pain was only here on this side. So when we went in, sure enough, it was ruptured, but it was contained within a phlegmon. The abscess was contained within a phlegmon. So, swerte siya. But there are some patients wherein the purulent material or fecaloid material does not get contained. So that is going to be associated with a higher chance of morbidity and mortality, because those patients with generalized peritonitis are going to have sepsis and then septic shock maybe later on if it is going to be left untreated. So there are many signs. Thoughts, obturator, dumpy. Actually, there are still more signs. No? There are a lot. So if a patient is uncomplicated, it can either be congestive or suppurative. It's complicated if it's gangrenous or ruptured. Now, there are some patients who might come into the emergency room or your clinic, and then you might examine them, see the labs, and then you will not be able to pinpoint whether it is appendicitis or not, because the history and physical examination and maybe also the laboratory findings are not going to be conclusive. But you have this index of suspicion that it's not negative also. So we classify these patients as equivocal. So you just have to admit a patient with equivocal appendicitis. Take note that imaging is not routine with appendicitis. More often than not, appendicitis is diagnosed clinically. Imaging is only reserved for those patients with equivocal appendicitis, or maybe those patients who were examined by another doctor, and then they did all the tests, and then they referred the patient to a surgeon. Actually, what is more important would be a CBC. So, a CBC with a leukemoid reaction, like WBC count of 18,000 and above, with segmental predominance maybe of 85, 95%, could tell you that this appendicitis is most likely the complicated type. So, the imaging of choice for appendicitis is going to be a CT scan of the abdomen. Ultrasound, however, is being done more because it's cheaper. And then, Pinoy biyata mga grabe tamad tipid, no? So, for the treatment, if you remember your chapter on sepsis, you have to give antibiotics, you have to hydrate the patient, and then do source control. So source control could be the surgery itself. Pinaning mga politiko, no? Kadabuntag yun, up down, right? Ito kay Clarex. Anyway. Okay. So with source control, it means operating on the appendix. So what we do is basically remove the appendix, but if there is peritonitis, spillage of maybe purulent or fecaloid material, we have to perform a lavage. So a lavage is just irrigating and then suctioning what you put in. So it's going to decrease the bacterial contamination in the abdominal cavity. And then you may put a drain, or you may not need to put a drain. If the appendicitis is not complicated, then no need to put a drain. But if it's a complicated type, in most cases, you need to put a drain. So sometimes we operate on patients and then we get a negative exploration. So there are two schools of thought na just remove it na lang. Okay, anyway, nag-iwan na ka na rin. Another school of thought is just leave it alone because it's not a diseased organ. So whether you want to remove it or not, that depends on you. As long as you explain to the patient why you need to remove it, and of course, there's no right or wrong answer here, as long as you're able to justify it, okay? It's also important, like let's say you made an incision here, and then the patient, and then you remove the appendix, and then let's say 10 years from that point, makita na naiiwan na rin yung patient, and the patient has abdominal pain again. And then they can already rule out that it's appendicitis because the appendix already has been removed. Yeah? So, weather, so depende na lang na. So there are other things, other disease entities that can be mistaken for appendicitis because their clinical presentations could be similar, like an variant torsion, Meckel's diverticulum, or tumors. So if you have those, you have to treat them accordingly. Like if it's an variant torsion, resect or oophorectomy. If it's a Meckel's diverticulum that's inflamed, then you need to do a diverticulectomy. If it's an appendiceal mass, you know that, no? So there is this condition called chronic appendicitis. Although it is rare, but it can happen. I think I can only count with 2 hands the number of times I've seen patients with chronic appendicitis. Last one maybe was last year. The patient had the pain for, I think it was on and off for 2 or 3 years. Seaman. Then every time magsakit, banat antibiotic. So it can happen. There's also stump appendicitis. Now, we resect the appendix usually at the base, meaning at the junction where it is, the junction between the appendix and the cecum. No? If there is an inadequate resection, meaning that there's maybe a little bit of appendix that has been left behind, that might also get inflamed in the future. And the problem here is there's a higher chance for it getting inflamed because the lumen is going to be narrower due to the previous bout of inflammation. Because if you remember in pathology, one of the things that happens after inflammation is going to be contraction, wound contraction. And this is a hollow organ. So what happens to hollow organs is usually luminal narrowing. So mas dali ra maka sulod diha ang mga picalit or maybe worms. I had a patient, did I mention this? I had a patient 2 or 3 months ago, appendicitis, but the biopsy result turned out to be schistosomiasis. So may mga nakaabot na ito na schistosomiasis sa appendix. Appendicial neoplasms. So, the 2 important tumors to note are going to be adenocarcinoma and a carcinoid tumor. For adenocarcinoma, always do a right hemicolectomy for cancer. You can do an appendectomy alone if it's a mucosal, lamb, adenoma or serrated adenoma. And you can also do an appendectomy alone if it's a carcinoid tumor, 1 centimeter or less, located at the tip. 1 to 2 centimeters is controversial, but if the tumor is more than 2 centimeters, then right hemicolectomy. So the only instance wherein a carcinoid can be resected only with an appendectomy is less than 1 centimeter located at the tip. But everything else, right hemicolectomy. Okay, let's go to the last topic. So inguinal hernias is very, very technical topic, no? It's more of a review of anatomy in weird angles and then the techniques themselves, no? So, just review the important structures, no? from inside, this is what you're going to see. So a direct hernia is going to pass through the deep inguinal ring. Okay, there's the back triangle on the borders and the adjacent structures to those borders. Inguinal hernias can be direct, indirect, or pantaloon. It should be a combination. So, indirect hernias are congenital, direct hernias are acquired, pantaloon hernias are a combination of both. So, an indirect inguinal hernia goes down through the inguinal canal and may enter the scrotum. A direct hernia just goes forward, no? Protrudes forward. Does not go to the scrotum. So just know the differences and then you'll be fine. But anyway, the management is still the same. Direct, indirect, pantaloon, management is the same. So an hernia can be reducible, incarcerated, or strangulated. So reducible, balik-balik na siya. Incarcerated would mean that it gets trapped within the defect. So the contents are there, but the vascular supply has not been compromised yet. For a strangulated hernia, the vascular supply has already been compromised. So there could be initially edema formation, similar to a closed loop obstruction. Edema formation, and then all of the inflammatory signs are going to shoot up. And then later, if left untreated, may become gangrenous and may rupture. So similar to an appendicitis, no? But of course, the presentation is going to be different depending on the herniated organ. So if it's just omentum, then not so deadly, no? But if it's going to be a loop of small intestine, then of course, the normal stream of the bowels is going to be disrupted, which is not compatible with life. So most hernias are diagnosed by physical examination and history. Only on rare instances would you need to use imaging. Let's say, for example, if you have a problem in diagnosing it, like the defect is very small, you cannot really examine it properly, or maybe the patient is very big, and then you can't really observe the patient say, hey, God, the board, but it's hard to detect at the time of examination, then maybe you can resort to certain imaging modalities like an ultrasound or a CT or an MRI. But this is rarely done for inguinal hernias. So the treatment is always going to be surgery. However, there are some patients who are bad candidates for surgery, like they're unstable, they have unstable comorbidities. So you can delay the surgery or not have the surgery done at all, but there's always going to be that risk of incarceration and strangulation that would loom above the head of the patient. No? So there are surgical options, tension-free, and tissue repair techniques. So what is important here are to know the differences. Show this, what layers, no? Pacini. Show this, 3 layers, no? Show this 2 layers. Pacini, 3 layers sutured into 1. Then Wittgenstein, Taptep, Hypom, robotics. So for the tension-free repair techniques, we use a prosthetic mesh. So the most common material used for the mesh is going to be polypropylene. It's a form of plastic. It does not seal the defect by being a barrier. It stimulates granulation formation. So the term used is going to be a scaffold, no? It's going to be a template where the granulation tissue is going to grow inside or within or around the mesh. So there is no tension involved. That's why it's called a tension-free technique. Now, for tension-free repair techniques, one of the most important steps is going to be to do a high ligation of the hernia sac, because a sac does not develop right away. A sac it will take years or even decades for a sac to develop. The sac is usually a protrusion of the peritoneum, which becomes abnormally configured depending on the size of the defect and where it is going to traverse, maybe if it's going to be direct or indirect. Okay, so just know the differences between these repairs, no? Complications. So there are many complications that we can see from hernia surgery, like chronic pain, it could be urinary retention, injury to two of the important nerves to note are the ilioinguinal and iliohypogastric nerves. So injuring these nerves can result into chronic pain on the inguinal region. Sometimes it can also result into erectile dysfunction in some patients. There could be chronic groin pain also. Recurrence is one of the complications that we really wouldn't want to happen, because it would mean that your procedure failed. Although it can also be due to patient factors, like maybe the patient post-op, manaminasi mo, balik ko marathon, or nag-gym, and then pag gawas balik, no? Sayang. Yung buwan sudok, yung buwan lagi yan. Kasi kagbugat, no? Easy. No? How you treat recurrences is going to depend on the procedure, the initial procedure that you did. So we have what we call procedures in terms of the approach, meaning it being anterior or posterior. Anterior approaches are usually the ones that are open, Cassini, McVeigh, Scholes, or a Liechtenstein repair, wherein the mesh is placed anterior to the defect. Posterior approaches are going to be tap, tap, iPhone. So usually those laparoscopic procedures. If the initial repair was an anterior procedure and there's a recurrence, your procedure of choice is going to be a posterior approach, and vice versa. Huh? Why? Because you did dissection over the area. And then if you did a tension-free repair, you put in a mesh. A mesh is going to cause granulation, and it's going to be incorporated in the surrounding areas. So there's going to be a lot of scarring, and you will not be able to identify the structures in the area. So you might end up maybe resecting the nerves, maybe even resecting the bladder. So that can happen. That's why the best thing is to do a different approach. So your initial repair was anterior, recurrence happened, then you do a posterior approach. Hematomas can also develop, like maybe you severed a blood vessel and then you failed to control that bleeder, or maybe the patient has been taking anticoagulant medications, so then after you see a violaceous discoloration of the area with some form of swelling. Damage to the spermatic cord structures. So in indirect inguinal hernias, since it comes through the patent processus vaginalis, one of the most important structures that goes with the sac is going to be the vas deferens. During hernia surgery, there is a chance, if you are not careful, that you might damage the vas deferens. So okay lang, napabitaw pikas, no? Pero, primo non nocere. Bladder injury. So, in hernia surgery, especially in the preperitoneal or posterior approaches, there's the chance of injuring the urinary bladder. So one of the things there is decompress the bladder by inserting a Foley catheter. And of course, the more important thing would be to be familiar with the anatomy of the patient. And of course, the anatomy should be ingrained in your brain if you're going to operate that. Okay, that's the thing about surgeons. May miss anatomy. Bladder injury, infections. Okay, that's self-explanatory, no? Like you were doing an hernia surgery and then nailangaw kalit na nilanding sa field. Or you were doing the surgery and then ano na yung singot contaminated. So infections, if it's a tissue form of repair, infections are not that much of a problem. But if you put in a mesh, it's going to be a very big problem. Because the mesh is a foreign object. No? And then, if you have foreign objects, foreign materials in the body, there is going to be very poor antibiotic penetrance. So, muning pinakakontra po sa mga orthopedics, especially if they put in metal implants and then it gets infected, nasakit sa ulo. So they just end up removing the implant. So same, if you have an infected inguinal repair and you used a mesh, you have to remove the mesh. Osteitis pubis. So this is commonly observed if the pubic tubercle is sutured during the hernia surgery. So you can just, in many cases, it will just go away. But if not, then chronic pain can ensue. Vascular injury. Take note, there is close proximity to a very important vascular structure, namely the femoral artery. If you palpate the groin area, you feel a big pulsation. No? That's the femoral artery. Visceral injury, this is going to be common. This is going to be more common or in those intra-abdominal procedures. Because if you're dealing with the anterior approaches, you're not going to encounter the bowels that much. Bowel obstruction. So, not likely, but it can happen because atong mga bowels are weird in a certain way. You just touch them a little bit and then they'll get inflamed and then they'll start sticking to one another. Huh? Okay? So, usually I think this is it. Huh? Na. So, for your exam this coming Saturday, just go through, I will just suggest that you go through these slides. Huh? And of course, for the anatomy part, physiology part, just review them. And then for terminologies, okay, they're in your book. Right? So, when it comes to treatment, you have to develop a certain, or maybe I would suggest that you make a flow chart. No? If A, then B, then another one. No? Okay, basically that's how treatment protocols are in general. But it doesn't necessarily mean that they are going to be followed to the T, but since you're still students, that can be a big help to you guys. Ha? Okay, di pa man mo makapasikat-pasikat or makahanap pa kay pa mo sa student level. Okay? Okay, so anyway, your bonus test. Sige, I'll give you